All right, we'll get started. So thank you for joining the Sumaira Foundation from the Expert Series. Let's see, my name is Nicole McLeod. I am the New York State Ambassador for the Sumaira Foundation and also the Grants Manager. We are dedicated to raising awareness for neuromyelitis optica and MOG. We also fundraise for research, and also we're pretty passionate about making communities for clinicians, patients, caregivers. Please join me in welcoming Dr. Sotirchos, who will be talking to us about nerve pain. Feel free to populate any questions you have in the chat, and there's also a Q&A function. They will be answered in the order they were received. I'm going to turn it over to you.
Great, thank you so much. I just wanted to say, first of all, that I'm really pleased to be talking about today, and thank you for the invitation to discuss at the Sumaira Foundation for NMOs from the Expert Series. My name is Elias Sotirchos. I'm an assistant professor of neurology at Johns Hopkins Hospital, and I'm a neurologist specializing in neuroimmunological conditions, including neuromyelitis optica spectrum disorder, MOG antibody disease, and multiple sclerosis. And that is kind of my outpatient practice, as well as inpatient. I care for people with these conditions. And so I've had an interest in NMO and MOG-AD and MS for quite some time. I've been in working in the field, both in research and clinical capacity, for about 10 years total. And I've been directing our specialty clinic here at Johns Hopkins that's dedicated to people with neuromyelitis optica spectrum disorder and MOG antibody disease for the past 2.5 years actually now. And I have to say, I mean, this is a quite a challenging topic that I was invited to discuss today, the topic of pain in these conditions. And I have to say, it's one of the symptoms that is one of the most difficult to manage, as well as one that impacts the quality of life of our patients in a very significant way. And I think that it's a field in which there's much to be done and much research needs to be performed in order to improve both our understanding of how pain develops in NMO specifically, as well as MOG-AD and other conditions, and how it may differ actually in how it develops, and in order to develop better ways to treat pain related to nerve pain in these conditions. So I think just starting overall to discuss kind of what is the frequency based on the studies that we have of pain in NMO and MOG-AD and in multiple sclerosis. And I think that, first of all, just looking at the studies that are available, it seems that it's very highly prevalent in people with neuromyelitis optica, with more than 80% of patients reporting significant pain that affects their quality of life. And this contrasts to some extent to multiple sclerosis, in which while pain is a significant and prominent symptom, it seems that it's not as prominent, first of all, in terms of its severity, and its prevalence has been reported to be around 50% of people with MS. MOG antibody disease is kind of it's more recently described, so the data is still somewhat lacking in terms of formal studies in order to evaluate, but about 70% of people with MOG-AD do report pain. This varies though, and it is often more prominent in the context of relapses, attacks, rather than chronically, although a significant proportion of people with MOG also have chronic pain with which to deal, although it may differ in the characteristics compared to NMO. And I have to say that this data is also kind of corroborated from what we see just in our clinical experience in daily clinical practice. People with NMO often report pain very frequently at their visits, and it's a topic that we often are able to control and prevent new relapses and attacks. But the treatment of pain is somewhat more difficult, I have to say, and more challenging, and often requires repeated visits, repeating discussions, trials of new medications, different approaches in order to treat that pain, because it is a challenging symptom to manage. So in terms of the pain, as I alluded to previously, there's different types of pain and different contexts in which pain can occur. First of all, pain can occur during an acute attack. And often, actually, the pain might sometimes precede the onset of symptoms of the attack in terms of the pain develops first, and then over a period of several hours to days, patients may develop then, depending on the location of the attack, if it's in the spinal cord, may develop weakness, numbness, bowel or bladder dysfunction. Whereas with optic neuritis, so in which the eyes become involved, often the optic neuritis, the first symptom that people may report is pain behind the eye that is worse with eye movements, and often associated potentially with a more general headache that might have migrainous characteristics, especially in MOG antibody disease that may occur. Now, that is kind of the one type of pain, and that type of pain may improve with the treatment of the acute attack, with steroids, with potentially plasma exchange if necessary, or other treatments. However, often, unfortunately, that pain may evolve into a chronic pain that persists for months, years, even decades beyond that initial attack occurring. And that seems to have to do with the long-lasting effects that that attack may have had on the nerves in the spinal cord. Typically, chronic pain related to optic neuritis is less frequent, although some patients do report persistent discomfort even years after optic neuritis. Now, in terms of the pain, I'd like to kind of break it down, first of all, in terms of the pain that's related to spinal cord involvement, which is the most frequent type of pain that we observe. And this can have a variety of characteristics. The most frequent one, which occurs in most of these conditions in NMO and MOG-AD and in multiple sclerosis, is what we call a type of central neuropathic pain. And this is typically described as a often tightening sensation or a band-like sensation across the torso, across the chest, or across the abdomen, depending on the level of the spinal cord that is most affected. This can also occur both in the context of the acute attack and often preceding an episode of spinal cord inflammation, but may also persist in patients, as I was mentioning previously. Often patients may describe this as feeling like somebody is squeezing them, or a very tight hug. In the MS world, this is termed the MS hug, is a term that's often used. And it can be a very challenging symptom and often very debilitating for our patients. Now, in addition to this kind of tightening sensation that can occur, there are other descriptions that people will often give to their pain, which can be kind of a different type of neuropathic pain, which is more tingling, burning, electrical, or even kind of stabbing, it might be described, or like this chronic aching sensation. This also can occur in the torso, but also in the limbs as well. So often if somebody has had an episode of myelitis, kind of where the spinal cord has become inflamed below the level of the myelitis that occurred, people may have kind of persistent symptoms like this. And sometimes more rarely, there might even be kind of a type of itching sensation that is prominent. Otherwise, another type of pain that may occur is also an electrical sensation, but it's classically described that it's kind of brought out by bending the neck forward. This is called the Lermite sign, and is a type of pain that may occur in all of these conditions. Typically also may fluctuate and may occur more frequently in the context of acute attacks, but sometimes patients have persistent sensation of that, where with flexing the neck, they get an electrical sensation down the back, which may or may not be painful. Now, the pain that I described here is often people will describe it as being fluctuating or constant. It can occur spontaneously without kind of a clear trigger, but sometimes can be induced by kind of a sensory stimulation. So something up against the skin, either a tight shirt or a tight belt, or just something brushing up against an area of the body that is hypersensitive. And this can be called, the medical term that's often used as allodynia. And this means that it's a sensation that is normally not painful that induces pain. Alternatively, people may have what's called hyperalgesia, which means that a stimulus that normally would produce pain causes pain that's out of proportion. So we often see this in the clinic when we're examining people's sensation, where we'll use sometimes either a cotton swab that we've cut in half and is a little bit sharp, or sometimes people will use safety pins in order to do kind of a neurological examination. And we see that, of course, this is a somewhat painful stimulus, but we'll see that sometimes people will experience in an area that's hypersensitive a pain that is kind of out of proportion to what we would expect with these types of stimuli. So that's the one type of pain, and that's the most frequent type of pain that's described in all of these conditions. With an NMO, about 80% of people reporting this pain. In MS, it depends on how many, if these patients have myelitis, but overall it seems to be 40 to 50%. Now, another type of pain that seems to be very specific to neuromyelitis optica is what's called paroxysmal tonic spasms. And this has been described to be occurring in about 25 to 40% of people with NMO. And actually has been proposed to even be relatively specific for NMO, in that people who have spinal cord inflammation, so transverse myelitis from other causes like MS or MOG-AD, seem to experience this at a much, much lower frequency, less than 5%. So if somebody has had myelitis and has these paroxysmal tonic spasms, it seems that that should kind of immediately raise in the neurologist's mind the possibility that this is NMO rather than another condition. And so what paroxysmal tonic spasms are, is these are typically involving the limbs, and it's a painful muscle contraction that's localized typically and will last for several seconds and is very painful when it occurs, and it can recur, but it's kind of episodic and paroxysmal in nature. Another type of pain is related to what we call spasticity, and this is a response that the body has after an episode of myelitis, in which kind of the legs can become very stiff and the muscles become contracted to some extent, and that can also lead to a kind of pain that's somewhat different from the central neuropathic pain that I was mentioning, that it's more kind of related to the stiffening up of the muscles, muscle spasms, and that's a rather a frequent cause of pain as well. Now, apart from the pain related to myelitis, I mentioned previously that pain is often a very frequent manifestation in optic neuritis. Most patients with optic neuritis will actually report in the acute phase that they're having this sort of pain, typically prior to the onset of visual symptoms. So it might be first kind of a little bit of an ache behind the eye, then pain that's worse with eye movements, and this will worsen over a period of several hours to days, and then people will notice the blurry vision. Although painless vision loss can occur, especially in NMO, when kind of the back part of the nerve is affected. Now, this pain typically will get better after the episode of optic neuritis. Typically with the steroids, actually, when we give steroids for optic neuritis, patients will report that the pain is the first symptom that gets better, whereas the visual symptoms may take more time to improve. So they may lag, and the improvement can take weeks to several months in order to occur. However, we do see people who have had a previous optic neuritis, and then in the context of stress, being tired, not getting a good night's sleep, maybe having other things going on like an infection, we see that they have this fluctuating discomfort in the eye that they described even up to months or years out from an optic neuritis. And we do an MRI, we do vision tests, and everything seems to be stable. But for some reason, it seems like the scar that has developed from the optic neuritis, and sometimes that tissue might become irritated for various reasons, and people might have some persistent pain after optic neuritis. Now, otherwise, in terms of pain related to optic neuritis, it's been reported more recently that perhaps people with MOG antibody disease may have other types of characteristics to pain and optic neuritis that may differ from other causes. With many people with MOG who are having optic neuritis reporting, in addition to that kind of typical pain behind the eye that is worse with eye movements, a kind of more extensive kind of headache that sounds almost like a migraine also occurring at the same time. And MOG patients often frequently will have more severe pain in the context of acute optic neuritis, because first of all, the optic portion of the optic nerve that is affected in MOG is typically the further in front part, which is adjacent to structures that become more irritated, and that way they have more frequently pain as well. Now, in terms of in the clinic, how we approach pain, so I mean, the first thing that we try to do is to clarify the pain characteristics in order to understand what the underlying cause is. Is this what we call central neuropathic pain that I mentioned? Is this spasticity? Is this a paroxysmal tonic spasm? Or is it some other type of pain? So if people with these conditions are not immune to getting pain that people in the general population like to experience, like things related to arthritis, for example, or sometimes people can have nerve pain that's not central from the spinal cord, but what we call peripheral neuropathic pain, which is from nerves being involved in the limbs, with things like diabetes or other causes being common causes of that type of pain. So that's really the first thing to try to do, to clarify what is going on in terms of pain. Then I think the next important thing, first of all, after kind of localizing where the pain is coming from, is to also understand whether this is an attack that could be an early attack. So are there other signs going along with it? Are people experiencing weakness, numbness, worsening of the neurologic symptoms otherwise? Or is this pain that is related to the prior attack, that's chronic pain that we have to manage differently? Because if this is an attack, that's something that we're going to, at least in the acute phase, obviously try to treat the pain, but also try to treat with steroids or plasma exchange or other treatments that we employ for when people are having acute attacks. And then it's very important to discuss with the patient and understand how severe this pain is, how it's impacting their quality of life, and what kind of interventions they would be interested in potentially undertaking in order to improve their pain. This often has to be tailored to the specific patient, since the treatments that I'm going to discuss often can have potential side effects, and people, depending on kind of their individual kind of values and beliefs, may want to approach the treatment of the pain in a different way. And there are multiple valid approaches to treating this type of pain, and it's a partnership between us and the person in front of us in order to treat this pain in the best manner. Now, in terms of treatment, I have to say, and this kind of comes to my initial comment, that this is an area where I think much work remains to be done, is that overall there's a lack of good quality, what we call randomized controlled trials, specifically in neuromyelitis optica or MOG antibody disease, to look at treatments of pain and if whether they work and to what extent they work. And when we say randomized controlled trials, this is kind of what the gold standard in our medical research in order to understand if something truly works, where we kind of take people who have a symptom like pain and we flip a coin and assign people to receive one treatment versus a placebo potentially, or a sham treatment if this is kind of an interventional pain treatment potentially, and then compare the outcomes, because that way we're seeing an outcome that's not affected potentially by other factors. And to some extent, the lack of this evidence in NMO and MOG has to do with the rarity of these conditions, and also the fact that we're extrapolating a lot of evidence from other conditions because we want to treat the pain in front of us when we see our patients suffering. So a lot of people might be also reluctant to enroll somebody in a clinical trial where that patient may be exposed to a placebo, and patients themselves may be reluctant to do that because of the fact that the pain may be so debilitating that we need to take action now. So generally, most of the kind of interventions, treatments that I'm going to discuss, the evidence really comes from other conditions and other causes of neuropathic pain, as well as from evidence from NMO that's mainly derived from what we call observational studies, where people kind of report what their experience has been treating NMO, but not necessarily kind of these randomized controlled trials, which are what we like to see in order to get kind of an unbiased estimate of how these treatments work. So in terms of other causes of pain from which we have a lot of evidence and we use it more, these are things like multiple sclerosis, which is a much more common condition. So we extrapolate the evidence from that to neuromyelitis optica and MOG, since also MS is an autoimmune condition that often affects the spinal cord. So to some extent, we can generalize the knowledge from MS to these conditions. Other is traumatic spinal cord injury. So people have had accidents or some sort of trauma to their spinal cord, and often pain there is also a very debilitating symptom. And so there have been some trials there from which we can extrapolate evidence. Others are what are called trigeminal neuralgia, which is pain involving the nerve that conveys sensation from the face, where people may have often very severe facial pain, as well as what's called post-herpetic neuralgia, which is when people have had shingles. And often following shingles, people have a type of nerve pain that can occur in that area. And then other types are things like post-stroke pain or peripheral nerve pain, most often from diabetes. And so we really extrapolate and take all that evidence and put it together in order to kind of inform our treatment approach in neuromyelitis optica and MOG-AD type disease, which are rare conditions and where we have less evidence for treatments. Now, just stepping back in terms of treatments, I think first of all, we have to divide our treatments, especially our kind of medication treatments, into two categories for NMO and MOG antibodies. So one is kind of our treatments that are there in order to prevent new attacks from happening. And so there are various treatments that are used. These are treatments that people remain on continuously in order to prevent attacks and act on. Typically, these treatments are used in a way that they act on the immune system in order to calm down the immune system and prevent new attack from happening. Now, generally, these treatments, really the way that we understand them as treating pain is by preventing an attack from occurring in the first place in order to avoid damage occurring that can then lead to chronic pain. So that's really the one cornerstone of treatment of these conditions, to prevent the attack from occurring in the first place. Then if somebody is having an acute attack, that can also be painful. Treating with things like steroids and potentially plasma exchange or other acute treatments by decreasing that inflammation in the acute stage can help with that acute pain. But then often we need to move on to what we call symptomatic treatments, which are treatments, that medication that we are using that are really, their goal is to alleviate the symptom of pain that is occurring. And there are many medications, I have to say, that may be used in clinical practice in order to treat pain in these conditions. Many of these are kind of off-label, essentially, to some extent, because we don't have have been approved for treatment of nerve pain and other conditions that I was mentioning previously, like diabetic neuropathy or other conditions. Overall, they fall into a few categories. I'm going to start with the first one is medications that were originally mainly developed for treatment or prevention of seizures. And there are many medications from this category that are often used for treatment of nerve pain in autoimmune conditions that affect the spinal cord. And the rationale there is really that seizures are essentially caused by overexcited nerves that just keep firing off electrical signals. And to some extent, the pain that is occurring in people who have had spinal cord attacks is due to the fact that there's some degree of kind of scarring and injury to the spinal cord in a way that makes nerves that are there to convey pain more excitable. And they're kind of firing off electrical signals inappropriately, and that's leading to this chronic pain that our patients are experiencing. And so seizure medications act in a way that kind of inhibits this kind of electrical signal transmission from the nerves. And there are several that have been used and tested in the treatment of nerve type pain. Typically, often the first line treatments that will be used in a lot of these situations is what are called gabapentinoids. These are gabapentin, also called Neurontin, or pregabalin, which is called Lyrica. And these are medications that are often used as first line agents for treatment of pain in neuromyelitis optica, especially kind of that central neuropathic pain that I was discussing previously. Now, other antiepileptics that are used are something called carbamazepine, is frequently used, also known as Tegretol, and is used rather frequently as well. This one is used both for central neuropathic pain, but also has been in reported kind of studies of people with paroxysmal tonic spasm, seem to be rather effective at controlling those as well. So in somebody with paroxysmal tonic spasms, it's often used potentially as a first line as well. And then there's a whole list of other kind of anti-seizure medications, including topiramate, niacinamide, lamotrigine, older ones like phenytoin, that are sometimes used off-label for treatment of pain and neuritis optica. That's really the one main category of antiepileptics. Then another category that's often used is these are medications that were often initially designed as antidepressants. And it seems that antidepressants, they affect the way that signaling molecules within the brain and spinal cord that convey pain sensations fire to some extent. And so there have been studies that support the use of these agents for treatment of neuropathic pain, with really two main categories being used, one being what are called tricyclic antidepressants, TCAs, which include amitriptyline and nortriptyline. And then another category are what are known as serotonin norepinephrine reuptake inhibitors, or SNRIs, and that includes a medication called duloxetine and also venlafaxine, which are also known as Cymbalta and Effexor. And these medications seem to act in a way where they're augmenting serotonin and norepinephrine transmission. And it seems that those signaling molecules may help to calm down those nerves in the spinal cord that are firing excessively and leading to patients developing pain. Now, those are really, I have to say, the first line treatments that are most frequently used. Often these may be used as a monotherapy, so just one agent on its own. But sometimes, especially in situations where we're having difficulty controlling the pain, we might use kind of medications from two different classes as a combination in order to try and get a better effect. Although we always have to be careful in these situations, since all medications can have side effects, and we always have to be aware of kind of potential interactions between medications when we're using more than one medication, as well as interactions with other medications that someone may be on for other reasons as well. So that's something that we always have to be aware of as treating clinicians. Now, this kind of brings us to less frequently used medication type treatments. There is a medication that has been studied to some extent for neuropathic pain and does seem to have efficacy, called tramadol, which kind of falls into a category of opioid medications, actually. Although this medication, in addition to its opioid-like effects, also actually has effects similar to what I called SNRIs previously, that affect serotonin and norepinephrine transmission. And it kind of has both of those effects and has been suggested to be effective for treatment of neuropathic pain as well. Otherwise, classical opiates, we generally try to avoid to use due to the kind of side effect profile, the potential for people to develop dependence on them, but also due to the fact that there have been a number of studies that have supported that with opiates, sometimes we can kind of potentially even paradoxically increase pain in patients. And often people who are on opiates might need to keep increasing their doses just to have the same benefit that they may have had on a lower dose. And sometimes this can kind of lead to a paradoxical increase of their pain, actually, because the body gets used to these opiates. So generally, those are really used, I would say, as a last line of treatment, and generally are avoided by most neurologists and pain specialists when we're treating pain. Now, there are other medications that can be used for pain, including for pain from spasticity, which is something that I did not mention. We've been focusing more now on central neuropathic pain and tonic spasms. So spasticity, there are a number of medications that can be used in order to help to loosen up the muscles, including baclofen, tizanidine, gabapentin, and pregabalin that I mentioned previously. And then if patients are still experiencing significant stiffness, sometimes people may do things like Botox injections into the muscle that can help with the stiffness and the spasms. And even potentially some people might end up needing, if they require large doses of baclofen, there can be something implanted called a baclofen pump, in which they're essentially having baclofen infused continuously around the spinal cord, and that can have an effect on the spasticity. But generally, we approach this in a stepwise fashion and try to avoid implanting pumps. However, often it may end up being necessary. Otherwise, There's a lot of interest recently in the use of products that are derived from cannabis for treatment of spasticity and pain in MS and neuritis optica and in MOG-AD disease. The evidence there is not great, I have to say, overall, although there is support of some studies support an effect, especially on spasticity, but also potentially on neuropathic pain and MS. And there is actually an approved therapy, an oral spray, not available, however, in the United States, that is approved as an add-on for treatment of spasticity in other countries, but not available in the United States currently. And I think that this is an area where there's a lot of interest in order to better understand if those may be options for treatment of pain and spasticity. Now, in terms of the one last category from a medication perspective we're focusing on now is also using local agents to treat pain. So this can include things like local anesthetic agents that numb up the area essentially where the pain is originating from. And this may include what's called lidocaine, either patches or gels potentially. Additionally, sometimes people use something called capsaicin creams, which is actually derived from chili peppers. It's the active ingredient that makes things chili pepper spicy, essentially. And the rationale here is that that can stimulate the nerves in that area that are conveying milder pain or kind of sensation, and that can overcome this abnormal firing of the nerves that are conveying the more severe pain. And so that sometimes people have reported to be useful. And sometimes people try compounded creams where they combine lidocaine, capsaicin, and potentially other agents into these creams and use them locally. Now, in terms of kind of the principle of the medication therapy, generally, most of the treatments that I use are generally used as preventive therapy. So generally, they're taken around the clock for the neuropathic pain in order to prevent the pain from kind of coming on to in the first place. Because often, if we just use them as needed basis, they aren't really that good at preventing or treating the pain, really. Because of this, also. Generally, we really need, when we're using these medications, to do a trial of kind of 1 to 2 months before we have an idea on whether the medication is working. This for a few reasons. One, just these medications need time to build up kind of adequate levels in the body in order to have their therapeutic effect. The other reason is also because a lot of these medications, we typically start at the very low dose in order to kind of avoid side effects. And then we slowly increase them over several weeks to months. And so that's why it's important to really, in order to make sure that somebody has actually failed the therapy, to clarify kind of what dose they reached and how long they were on it. Because it might not necessarily be that it was that they failed that therapy, but it might be that it just wasn't an adequate trial potentially at a high enough dose or for a long enough time. And then, as I said previously, we have to be consider monotherapy versus combination therapies and consider all these kind of side effect profiles when we're combining multiple different agents. Now, in addition to therapies that are pharmacologic, so that are medications, I think it's important as a final part of prior to our discussion and Q&A session to discuss non-pharmacologic therapies. And there are a variety that have been proposed in order to that have been proposed to be beneficial for neuropathic pain. I think the most important is physical therapy and exercise, provided one is able to do these sorts of things in a safe manner, seems to be important in order to adjust the way that pain is being experienced, the way that these nerves are firing. Exercise is just has so many effects on the nervous system and really can even increase kind of the body's and nervous system's ability to produce what we call endogenous opioids or cannabinoids, which are kind of molecules that are similar to some extent to what's included in cannabis but naturally occurring. And so it seems that this can have quite an important benefit, not just in terms of rehab and acquiring back strength in people who have had impaired, who have weakness related to a prior attack, but also in terms of kind of modulating pain as well. So physical therapy and exercise are really kind of one of the cornerstones just in our treatment approaches in terms of both rehabilitation, but also potentially can help with pain as well. Then there is some interest and evidence for the use of what's called transcutaneous electrical nerve stimulation, or TENS. Although again, the trials that have been done in other conditions are relatively small, and there's some conflicting evidence. And this involves kind of putting electrodes on the skin in the area that is painful, and this TENS unit provides an electrical stimulation essentially, and that is supposed to kind of suppress the pain conduction in the spinal cord, kind of similar to what I mentioned previously, the approach with using capsaicin in order to kind of overload the nerves in that area and prevent the pain from being overwhelming. And so that's an area of interest. And I'm aware of a clinical trial going on with that in NMO with portable TENS units. Additionally, actually, the only clinical trial that has been performed in neuromyelitis optica spectrum disorder, to my knowledge, has employed a treatment that's somewhat similar, but a bit differently, called scrambler therapy, which is somewhat similar to TENS in terms of that it uses electrodes in order to provide electrical stimulation to the area, but it's different to some extent, its protocol. And a clinical trial performed by Dr. Michael Levy, who is here and is now in Boston for the past years, it's demonstrated in people with neuromyelitis optica that there was a significant benefit for pain. This was a treatment that was performed kind of daily, actually, for a period of 2 weeks, and people were followed for several months after that, and it seemed that there was a significant benefit for pain. However, it did seem that this benefit wore off after a few months, and so would require repeated therapies moving forward. Other non-pharmacologic therapies that may be used for treatment of pain include from complementary and alternative medicine approaches, including acupuncture. It may sometimes be used. I have to say the evidence there is somewhat lacking, and there aren't good quality clinical trials in general to support the use. However, I have to say I have seen people report significant benefit from acupuncture, although one of the limitations is generally it's a relatively short-lived benefit, so it requires repeated sessions in our patients who are experiencing pain. And then a final kind of consideration is I've seen some patients and pain specialists use spinal cord stimulators, which essentially provide electrical stimulation to areas adjacent to the spinal cord, with a thought being kind of similar to what we've been discussing about TENS, about scrambler treatments and other treatments, similar principle overall. I have to say this is also, the evidence is not clearly there yet for that. And this, with spinal cord stimulators, there are additional considerations, including that they may impact the ability to perform MRIs as well. And in people with autoimmune diseases of the spinal cord and central nervous system, there's often a need for MRIs. And so that's something that can be challenging if somebody has a spinal cord stimulator in place. But that is also something that is sometimes employed for treatment of pain in NMO. So that was all the ground I was hoping to cover in the talk in the initial part of the session. And let me see in terms of questions that we have in the chat now. So the first question here is about the bending of the neck sensation that I described, and about having this when rinsing shampoo from the hair and suddenly getting tingling in the arms, and they would almost feel heavy, like they had 10-pound weights in them. And the question is this possibly from MOG? So without kind of knowing the specifics, I do have to say that with the bending of the neck, there are kind of two things that have described potentially occur. One is what's called Lermite sign, which is this kind of electrical sensation down the back and potentially into the limbs as well. And that's often, we see that happen in people who have had lesions or involvement of the cervical spinal cord, so the spinal cord within the neck. And so that certainly could be related if somebody has had a prior episode of cervical myelitis. And then in terms of the weakness potentially, that is something that I did not mention previously, but there is a description of something called, it actually has an eponym called McArdle sign, in which people who have had spinal cord involvement, and this was actually described in MS, although the same principle would generalize to other conditions. So when people bend their neck, they might have this rapid development of weakness in the arms that, however, is reversible with putting the neck back in the prior position that it was in. And so that certainly could be consistent with this McArdle sign, actually. So the next question was, what about joint pain? I have been having pain in my wrist and kind of goes up my arm a bit at times. So that's a great question, and that's kind of one of the points that I was trying to make, is that it's really difficult at times to understand what necessarily the cause of the pain is. And so the pain, the neuropathic pain in NMO, we typically don't think that it's in the joint, although the traveling kind of from in various parts of the body does seem more neuropathic in origin. And so that's why it's very important when people are coming in for evaluation of pain for us to make sure that we take a thorough history and do a thorough physical examination in order to understand where the pain is coming from. Because as I said, people may have NMO or MOG or these very rare conditions, but that doesn't mean that they can't also get things that are common in the general populations, like arthritis type pain or other types of pain that are more common. And so joint pain specifically is not really what we consider to be directly due to NMO, although sometimes people may have joint pain, for example, from a secondary cause. So let's say that somebody has weakness in one leg more than the other, they might be relying more on one leg and overbearing it. And then I see people have musculoskeletal type pain in their stronger leg, for example, because they're relying more upon it in order to bear their weight. Or let's say somebody has more impairment in one arm than the other, they might be using their strong arm more for manual activities, and that can also lead to potentially having more pain in that limb as well. So it really depends on clinical examination, the history, knowing which part of the spinal cord was involved in the initial attack and which side was more severely affected, since generally we would expect the neuropathic pain to be more severe in the area that was injured during the initial attack and where the scarring may be more severe. So moving on to the next. So our next question is, my son has foot drop after spending around 2 weeks on a ventilator. Sorry to hear that. Probably because of proning. The pain causes severe burning and tingling. It is debilitating and disturbing sleep. The foot drop symptoms have not improved. He is taking Eptilem 300 milligrams and gabapentin that worked initially but not after a while. Also doing EMS, heat and cold, etc., and exercises. Can you please advise? So this is, I mean, I think that it's difficult to advise kind of without knowing the context, but I have to say that the foot drop related kind of positional injury potentially to a peripheral nerve, that would be kind of more the peripheral, that sounds like potentially more related to peripheral nerve involvement and compression. That often may get better over time without interventions, although it's difficult without knowing if it's spinal cord involvement or other issues causing the pain there. Now, it seems that here using kind of anti-epileptic therapies that I discussed previously that can help with the pain potentially, as well as local things and exercises. I think that this is definitely something to discuss with his neurologist and see if there are kind of ways in tweaking the medication or trying alternative medications in order to try and approach it. But if it is related due to proning and potentially kind of nerve compression, this is something that often may improve, but often the recovery may be somewhat delayed in order for the nerve to recover from that initial injury. Oh, I'm sorry, I moved down. Notes with NMOSD in 2015, alpha-4 negative. I see. So yeah, I mean, I think that it's very important to do a detailed exam and kind of try and see about tweaking medications in that context. Yeah, that's something though, that if it is due to proning though and the nerve being compressed, that often can improve significantly on its own with time. Now, moving on, there is a question about red light therapy, read good things about its use in MS. So, I mean, I think that I've heard a handful of patients trying to use these types of approaches. I have not seen, I have to say, trials or studies reporting this in multiple sclerosis NMO. So generally, I'm not aware of much evidence for that. Can magnesium help with pain, such as Epsom salt baths or magnesium supplements? So magnesium, we do use magnesium often in neurology for treatment of pain related to migraines. I have not seen good evidence or results for treatment of neuropathic pain, but I do think that it's something that people may potentially try, and that it would not be unreasonable. And doing things like Epsom salt bath and things like that. I mean, if people can try things like that as well, but generally that's used more for migraines in neurology when we're treating pain. Our next question is, my mother has intermittent shooting pain down her left leg. Her left leg has very limited movement, but I am curious if there's anything we do to ease the shooting pain. It lasts about 15 minutes, starts at the top of her leg and goes down her foot. 8 out of 10. Any suggestions? Also, is swelling related to this at all? Thank you in advance. So I think that this is also an interesting question and brings up kind of again, I think to some extent the point of where the pain is coming from actually. So this is a type of pain that we might see in people with spinal cord involvement from neuromyelitis optica, but also sounds potentially being due to sciatica, essentially, where you might have a disc or arthritis in the bottom of the spine that is pushing on the nerves that go to the left leg. And often this is described as kind of a shooting pain starting at the top, going down into the foot. And so to some extent, I have to say the treatment approaches are somewhat similar in terms of kind of these types of medications that I mentioned previously. And this is definitely something discussed with the neurologist, but also potentially physical therapy can help as well, because of if there is a nerve root impingement, physical therapy is often potentially helpful as well as other interventions that might be aimed at kind of treating that type of nerve impingement type pain. In terms of swelling, so there are many reasons why a leg can become swollen, including kind of heart conditions and other conditions as well. However, in the context of having weakness in a leg, the typical common cause of that is because of that weakness in the leg. So the way that, although again, this is something obviously to discuss with her physician, because there are many reasons like clots in the legs or other things, and so it's difficult to say. However, we do frequently see swelling in the limbs in people who are weak in a limb. The reason is that the way that blood is pumped out of our legs and the veins is by the muscles contracting. So the muscles contracting essentially squeeze the blood up so that it comes back up into the circulation and goes to the heart so that it can be pumped. And so if the leg is weak, if the muscles aren't contracting much, often the blood can pool in the leg, and that can cause swelling. That can also potentially lead to clotting, as I was mentioning. And so that's why it's important in general for the leg to be elevated if people are standing for or sitting for a period of the day, try to elevate the leg. Often compression stockings are used, and those types of approaches can kind of alleviate the swelling. And the swelling in and of itself can sometimes also cause pain, although the nature of it may be somewhat different than the neuropathic pain that I was describing previously. This would definitely be something to investigate with the primary care physician, just to make sure that there's no other cause of the swelling, and potentially with the neurologist and or primary care physicians. Primary care physicians also often treat this type of neuropathic pain, since it's relatively common from other causes like diabetic neuropathy that I was mentioning previously. So often primary care doctors will often manage this type of pain as well, but also something to discuss with her neurologist as well. So it looks like we have one more question. With MOG, if you get an infection of some kind, can it make you having a hard time to get rid of the infection, as in cellulitis? So with MOG, and generally with these conditions, NMO, MOG, MS, I was mentioning, it's generally thought that the condition in and of itself doesn't necessarily cause or lead to an increased risk of infection. What can lead to an increased risk of infection are probably essentially two things. One is treatments that are used for these conditions, because the treatments that are used typically suppress or change the way that the immune system functions to some extent. And so that can lead to infections or difficulty clearing infections as well. So that's the one aspect. The other aspect is if there is, and this is typically more with bladder infections, but if there is kind of some sort of permanent neurological disability that has accumulated, such as bladder dysfunction, that can lead to the bladder not emptying as well, which can lead to an increased risk of things like urinary tract infections. Then if somebody is unfortunately severely disabled, for example, they might be more at risk to get things like bed sores, for example, that can become infected. So those are really the two main ways, but otherwise, having MOG or having NMO or having MS in and of itself, it's not thought that the immune system is suppressed just by having that disease. It's more the medications that are used to treat the disease can make people more susceptible to infections. Looks like we have one last question here. Is there anything that would help nerve pain in feet? I am on a high dose of gabapentin and baclofen for spasticity in my calves and feet. I struggle with my feet burning and hurting when I walk. And so this would also be kind of, I mean, that definitely sounds like the feet burning and hurting, like a type of neuropathic pain. Now, one thing that could be related either to spinal cord involvement or potentially to peripheral nerve involvement as well. And so this is a situation in which it would be worthwhile, I think, discussing with a neurologist about kind of approaches to treatment of the pain, because there are many different medications, as I mentioned previously, that can be used. And so the feet burning and hurting, there definitely could be alternative options or additional options considered. And so discussing that, I think, would be completely reasonable, especially if the relief of pain currently on the current regimen is suboptimal. So that definitely can happen. And then our last question is about anything that can be done for numbness. So my mother has the tightening you suggested around her torso and also numbness. She also experiences this in her right. So I have to say, in terms of the things like weakness and numbness, unfortunately, there's not really much in terms of medications or symptomatic therapies that we can do for those things. Those things are generally kind of what recovery will occur after an attack. And often, if there has been kind of persistent numbness or weakness, that may remain over time. The things that we can do for those things are generally physical therapy, and exercise can really help in order to improve recovery following an attack and improve neurological function.
There was one that came in via the Q&A section that says, is there anything that would help nerve pain in feet? I'm on a high dose of gabapentin and baclofen for spasticity in calves and feet. Struggle with burning, my feet burning and hurting when I walk.
Yes, I think that, did I not read that question? I'm sorry, I answered
It was in a
but I might
separate
have.
section. Okay,
Yes,
I just wanted to make sure.
Yeah, I answered it, but I might have not read it out loud.
Yeah,
So
no
I was
problem.
mentioning that, I'm sorry. So I was mentioning that I think that it would be reasonable to discuss, given that there's suboptimal pain relief, to make sure that, see if there's an alternative cause, but also discuss potentially would they benefit from a switching or adding a medication in order to control the pain. So that's definitely something to discuss with their neurologist or primary care doctor.
Well, I want to thank you for your time today. This has been really, really informational.
Thank you so much for the invitation. It was my pleasure.
All right. Thank you. Take care.